I'm going to lower your gown.
Alrighty. Okay.
Can you lie back?
Mm-hmm.
In a quiet room, help the patient into a supine position and make sure he's warm.
Look at your chest.
Working from his right side, begin by inspecting the heart. To do this, aim a light tangentially across the chest to accentuate the surface flicker of the cardiac movements below. Look for the apical impulse, which should appear in the 5th intercostal space at the left midclavicular line. It should not be wider than one space or unusually prominent. If excess fat, muscle, or breast tissue obscures the impulse, ask the patient to sit up and lean forward. This brings the heart closer to the chest wall and makes the impulse easier to see.
Now I'm going to feel your heart movements with my
To
hand.
palpate the precordium, use a light touch and a methodical approach. First, place your warmed hand at the apex. Feel for the apical impulse. If palpable, it should lie at the left midclavicular line. The impulse should last no longer than systole and be no wider than 1 centimeter, and it should feel gentle with no heaves or lifts. Next, move to the left sternal border, feeling for a displaced or widened impulse or other abnormalities. Then palpate at the base of the heart to detect any problems. Fine rushing vibrations, called thrills, may be felt at this site. During palpation, determine the point of maximal impulse, which is where the apical impulse is strongest. With your fingers on that point,
Turn your head to the left, please.
use your other hand to palpate the carotid pulse, which should be synchronous with the apical impulse. If chest x-rays aren't available,
Mr. Parker, I'm
use
going to tap on your
percussion
chest
to
and make a
estimate
rough
the
outline
heart's
of the
size.
heart.
To begin, tap from the left anterior axillary line toward the sternum, moving along each intercostal space. Wherever the percussion notes change from resonance to dullness, mark these spots as the cardiac border. On the left side, resonance should disappear around the PMI. Then percuss along the intercostal spaces from the right midclavicular line toward the sternum. Listen again for the change from resonance to dullness, which usually occurs at the right sternal border. When you finish outlining the heart, measure it. In a healthy patient, expect to find 5 to 7 centimeters in the 5th intercostal space, 4 to 6 centimeters in the 4th intercostal space, 3 to 4 centimeters in the 3rd intercostal space, and 1 to 3 centimeters in the 2nd intercostal space.
Okay, can I have you sit up now?
Mm-hmm.
To continue, auscultate the heart with a warm
Now I'm going
stethoscope,
to listen to your
moving systematically through all the basic auscultatory sites. These include the aortic area, in the 2nd intercostal space at the right sternal border, the pulmonic area, in the 2nd intercostal space at the left sternal border, the 2nd pulmonic area, in the 3rd intercostal space at the left sternal border, the tricuspid area, in the 4th intercostal space at the left sternal border, and the mitral or apical area, in the 5th intercostal space at the left midclavicular line.
Okay, now lean forward a little and breathe quietly while I listen to your chest.
Plan to auscultate with the patient seated and in the supine or left lateral recumbent positions. Also plan to use the diaphragm of the stethoscope, inching from site to site. Then switch to the bell and do the same thing. Now assess the heart rate and rhythm, listening at a site where the tones are easily heard. In adults, the rate normally is 60 to 90 beats per minute, and the rhythm is regular. In children, the rate can range from 120 to 170 in newborns to 70 to 110 in 10-year-olds.
Your heart rate is normal. Now I'm going to have you take a breath in. When you exhale, hold it while I listen to your heart.
Okay.
At each site, first listen for S1 while palpating the carotid pulse. S1 should coincide with the rise of the carotid pulse. It should be high-pitched with a moderate intensity. Second, focus on systole, which begins with S1. You should not hear any extra sounds or murmurs. Third, concentrate on diastole, which should last longer than systole and also should have no extra sounds or murmurs. And fourth, listen for S2.
Take a deep breath in and hold it.
It should be high-pitched and may split during inspiration, which may be normal or pathologic.
Exhale and breathe normally.
When listening to heart sounds, characterize them by pitch, intensity, duration, and timing in the cardiac cycle. Analyze the 4 basic heart sounds carefully. S1 and S2 always occur and are the most distinct. S3 and S4 may also be heard and can be normal or pathologic.
Okay, breathe normally.
S1, which results from closure of the mitral and tricuspid valves, marks the start of systole. It's heard best at the apex, where it's louder, lower, and longer than S2. S2 is caused by closure of the aortic and pulmonic valves and signals the start of diastole. At the base of the heart, S2 is louder than S1. At all auscultatory sites, it's higher and shorter than S1. Note any splitting of S1 or S2. Because the synchronized closure of 2 valves causes each sound, closure that's out of sync can break the sound into 2. Although a split S1 is uncommon, it's most often heard at the tricuspid area, with the sound breaking into mitral and tricuspid components. Because S2 is affected by respiration, listen at the base for it to split into aortic and pulmonic components during inspiration. With expiration, expect a physiologic split sound to merge back into one. Splitting is relatively difficult to hear in older patients, possibly because aging tends to increase the antero-posterior diameter of the chest. Be especially alert for S3 and S4, which are heard best at the apex.
Okay, now squeeze my hand firmly.
To make these quiet sounds more noticeable, have the patient grip your hand
Good.
or
Now
raise
squeeze
his
again
legs.
A few more times firmly.
S3 occurs when blood filling the ventricles makes their walls vibrate early in diastole. Because this low-pitched sound happens right after S2, it produces a galloping rhythm, as in the word Kentucky. S4 results from vibration of the valves, papillae, and ventricular walls later in diastole. Because this low-pitched sound occurs just before S1, it produces a galloping rhythm, as in the word Tennessee. S4 is more common in older adults because they're likely to have decreased compliance of the left ventricle. In a patient with S3 and S4 heart sounds, you'll hear a summation gallop.
Now I'm going to listen to your heart some more.
If you have trouble hearing any of these gallops, listen with the patient in the left lateral recumbent position and use the bell of your stethoscope.
Now I'm going to have you lie back, Mr. Parker.
After identifying basic sounds, listen for extra heart sounds, such as ejection clicks, systolic clicks, and a pericardial friction rub. Ejection clicks are high-pitched and result from faulty opening of the semilunar valves. A pulmonic click is heard best in the pulmonic area during expiration. An aortic click is less sharp, is heard best in the aortic area, and is equally loud during inspiration and expiration. Mid to late systolic clicks typically are caused by mitral valve prolapse. They're heard best at the apex and are accentuated by inspiration. A pericardial friction rub occurs when the surfaces of an inflamed pericardial sac rub against each other audibly. A rub is most distinct at the apex, but may be heard widely. Its intense grating sound may occur throughout S1 and S2.
Please turn onto your left side.
Finally, auscultate for murmurs, which are relatively long sounds often caused by the backward flow of blood. As with any heart sound, if you detect a murmur, note its timing and duration. For example, a systolic murmur may occur during part or all of systole. Similarly, a diastolic murmur may occur during part or all of diastole. Also determine the murmur's pitch, which may be high, medium, or low. And rate its intensity. A grade 1 murmur is barely audible. Grade 2 is quiet but clearly audible. Grade 3 is moderately loud. Grade 4 is loud and associated with a thrill. Grade 5 is very loud with an easily palpable thrill. Grade 6 is very loud with a palpable and visible thrill. In addition, describe the murmur's quality. For example, a murmur may be blowing, rumbling, or harsh. Also note the murmur's location, radiation, pattern such as crescendo, decrescendo, or plateau, and changes with the respiratory phase. In children and adolescents, you may find innocent murmurs, which have no known cause. They usually occur in the pulmonic area, are grade 1 or 2, and disappear when the patient sits or stands. Although examination of the heart requires expert use of all the basic assessment techniques, you can easily achieve this level of skill with practice. And with this skill comes the ability to take your physical examination, health history, and laboratory test findings, and build a complete clinical picture of the patient's cardiac health.